here in beautiful Kensington Town Hall, and it's extra delight to be in person rather than online as we have been over the past period. So very welcome to all of you, and let me. No, we were hoping to have the newly appointed chief executive of Royal Borough, Maxine Holdsworth, join us this morning to greet us all, but unfortunately she's tied up in another meeting at Grenfell. So in place of Maxine, I'm going to ask Lucy to formally welcome us all this morning.
I just wanted to welcome you all to Kensington Chelsea and say how delighted we are to be hosting last Jobs Good 2022. We value these meetings so much, and I think when it comes to health and joint work across boroughs could not be more vital in this moment. So just wanted to extend that thanks.
Thank you very much for that, Lucy. So I think I can see, most of us have got the paper version of the copy. So why don't you have the electronic version? I'll be making reference to that in a moment. So if you're ready, then we'll start. So the first item is apologies, please. And I think, Hannah, you're going to be confirming that for us this morning.
So it has come from Nick Dennis.
Thank you very much for that. Any declarations of interest, colleagues? Let me start off with mine. So I'm the lead governor of Central and Northwest London NHS Foundation Trust. Anybody? Thank you. Deputations, Hannah? Not. Thank you. The minutes of the previous meeting, which was a while ago now, at equally beautiful Richmond. Shall we take that as tabled?
I have to agree, though,
yes. Are we happy to agree? Take it as tabled, and are we happy to agree?
So I'm happy to agree.
Thank you. Thank you, Marina. And thank you to our officers in Richmond for very helpfully preparing those minutes for us. Okay. Any matters arising that isn't covered elsewhere? And I know some information items remain, and we will pick that up later. But apart from that, any other matters arising, please? All right. Thank you very much. So we now come to our first main paper, our first substantive paper, and that is elective recovery and cancer care backlog. And we are joined by Leslie Watts this morning. Good to see you, Leslie.
Good morning.
And so we do have the paper in front of us, and the colleagues have all read it. We'd be pleased to know. So it'd be good if we could spend 2-3 minutes picking up and reminding us of the key headlines of that particular report before we move to questions and answers, please. Sorry, Rory.
Yeah, sorry, Chair. Just to say, Sanjeev Johal here as well from NHS.
Thank you. I was going to get Leslie to introduce other colleagues who are going to be helping with this paper. Thank you very much, Rory. Thank you, Leslie, and good morning to you.
Good morning, everybody, and it's lovely to be here too. And I'm Leslie Watts, I'm the Chief Executive at Chelsea Westminster Hospital. And for the press screening item, Sanjeev's here to help me. So, morning, Sanjeev. Thank you.
Good morning. Good morning, everybody. Hopefully, you can hear me.
Welcome.
Headphones.
So,
Good morning. Good morning to you.
just a bit of context then, Chair, if I may, and then from the sorts of things that we're doing. So, there is no doubt, that we are continuing to work in pretty challenging times, actually. So, the pandemic had a major impact on our ability to respond in terms of our breast screening, but actually in terms of all of our services, which you will see in the elective recovery paper. But just to put in context, actually, we looked at nationally, London is, I think, the best performer in the country, and North West London performs pretty well in the whole of London. Usually either first or second in terms of that. That still is not good enough. So we absolutely accept that. All of our trusts now are actually treating patients at the same level, and some better than the level of before the pandemic, so 2019. But in order to recover not just the backlog, but you will see running through the papers, the increase in some of the referrals, then we need to do even more. And to enable us, just to pull out our waiting list, so the PTL, our waiting list has increased by 5%. That's higher than any other ICS in London.
Leslie, sorry to interrupt you. For our friends on the screen and residents who may be tuning in, can you just spell out what PTL?
It's the waiting list. It's it's the patient tracker list, but it's our waiting list. And I'm really sorry, because I do know the NHS has its own language. And so absolutely, if there are other areas, but sometimes we forget because we're so used to it. But if there are questions about the language that we use, we'll try and clarify as much as possible. We've done a lot of work in North West London. You will have seen in the context that we believe that during the last couple of years there are a number of duplications on waiting list reviewing, and continue to work in North West London to make sure that our waiting list is as clean as it possibly can be, so that we've got everybody on there that needs to be on there, but we haven't got people on there more than once. And again, in North West London, we're leading much of that work. We're using something called Foundry, which you will know that we used during the COVID, which is a platform to make sure that we've got every patient accounted for. We're working together in terms of the acute collaborative, so the four acute trusts across North West London, so that we're in terms of the principle of treating our sickest first, so our most urgent, and then making sure that we treat those that have been sitting on the waiting list longest. That's an absolute principle for us. To enable us to do that, we put in mutual aid, so we help each other in particular specialties to treat each other's patients, so that we can make sure that nobody is left longer on a waiting list in one of our hospitals if waiting longer than patients in other hospitals. I think I'll stop and take questions, actually, if that's all right, Chair, because I think there's a lot of work going on. I'm sure there will be lots of questions, but I'm hoping that the paper covered as much of that as possible.
Thank you very much for that, Leslie. So let me just bring Dan in first, Dan.
Thank you, Chair.
Morning.
Good morning. Thank you for being here. What I would say is this is quite the cancer backlog in itself is obviously concerning in respect of the need to. We know how difficult it is to identify this disease and how unfortunately a missed detection can be. And the backlog, we understand the reasons for the backlog, but I think the committee would have concerns just in terms of some clarity on what is I have page 13, which is your first page, at the bottom there. The latest fully validated data, we're talking about around 250,000 patients there. I wondered if I know you won't be able to give us validated data at this point, but that's we will have perhaps an indication of what that figure may look like now and what progress has been made to, as the rest of the report details, make some progress on that. And just on this particular sort of point, the follow over the page, it talks about potential duplication between local and national waiting lists, and some work that's being done locally to try and sort of identify what the true picture is. I wondered if you could give us some clarity on any progress on those things.
So absolutely. So thank you. So and all of those are legitimate concerns. So in terms of the validation, that is a very real piece of work to make sure that actually, we are clear about who's waiting and how long they're waiting. And every single trust is working its way through that. And we report actually through trust boards on that work and how many patients are taken off waiting list or are validated in between every board meeting. So we'll make sure if it's more helpful, we can make sure that we send that into to you, Chair. And,
Thank you.
And if anybody, and I would say please not all of you, but if anybody is interested in the how we do that, then we've got a pretty robust process for doing it. So you're very welcome to come and have a look.
Thank you very much for that. Chetna, do you have a supplementary back of what Mr. Starnes?
Chetna.
Natalia or Chetna?
Sorry. Natalia.
No, I just wanted to ask a question about making it real in terms of the patients that have got concerns. I just want more understanding about that patient's journey.
Yeah.
If a patient at the moment has got a concern about physical symptoms that they have, what is the backlog and what are the waiting having? How do they impact those patients? Anxious about the symptoms that they have. Also, if you think about the waiting list, that people that are already on the waiting list that you recognize that also need to prioritize. So what happens with them as well? Can they also then tell them very sick, and how is that prioritized?
Yeah. So and you're right, patients' conditions can change. So we have a couple of things that you can do. So you will see that harm reviews take place while patients are waiting on a waiting list. So over a 52-week wait, then there are harm reviews undertaken on all patients to see if there's likelihood of any harm to those patients. In the meantime, if patients if their symptoms worsen, there's two things they do, and this happens frequently for patients anyway, which is they can go back to their GP and say, my symptoms have worsened, and the GPs can increase the way that our GPs refer into us are 2-week cancer away, urgent or routine. So they can increase what they're saying about that patient. But actually, patients do contact us directly as well, and every patient that contacts us, we will review them. The difficulty, of course, is always that for any individual patients, and understandably, that for them personally, it's the most important thing. For us, what we have to be clear is that we see people in priority in terms of appropriate priority to make sure the potential for our sickest patients and the potential for those patients that are most at risk is a principle that we stick to.
And how do you monitor that? How do you target that, and how do you ensure that that is really followed and nobody is in fact left behind for whatever reason, please?
So we review our waiting list on a regular basis. We're measuring. I mean, we're the scrutiny here, of course, but we're in scrutiny both in terms of from our colleagues at the ICS. So for our acute units and all of our hospitals, they're reviewed by our ICS colleagues. There is a focus meeting, particularly on this subject, with London, and the national data comes out, and trusts that flag go for a national review as well. So there is a escalating review process for it.
Thank you, Rob. You wanted to come in?
As a point of principle, and what North West London done has created a shared waiting list across the system, across the 4 hospitals, and that is, as Leslie reviewed regularly by clinicians, and every patient is prioritised in terms of category 1, 2, 3, and 4, and 1 and 2 we have the urgents prioritised, and they are getting treated. It's the category 3 and 4 where we go into chronological order and a regular review. So there's the regular clinical review of the waiting list in each specialty. There is the making sure that's bringing together for equality purposes. One of the biggest inequalities we have is when we have differential access to different hospitals for the same treatment, and that we've seen in the analysis that exposes great inequalities to communities. So bringing together, as Leslie says, the whole of the waiting list across the North West London population to ensure the equal clinical harm assessment and chronological prioritisation is an important inequalities issue and the reduction in inequalities issue. That we are then held to account on that on a very regular basis. So I'm talking about weekly, daily type of reviews of these waiting lists. if something changes, if a patient is concerned, and a new piece of information arises, contacting the GP or indeed the hospital, that new piece of information goes into that clinical prioritisation process that people, the clinicians, the doctors, the nurses, allied health professionals looking at and doing those clinical harm risk assessments will use that information to reassess the level of clinical harm. And those kind of reviews are taking place in our hospitals on a regular basis. There is also better communication than ever. I know we'll come on to pressures on primary care. At the moment, it's a big issue. Communication between primary care and secondary care, so GPs and the hospital clinicians, on being able to look at the same piece of information about a patient and not having multiple records, different pieces of information. So we've got a consistent line that feedback loop between the GP and the hospital clinicians. I mean, it's perfect, but better than ever before in terms of the consistent information available to make that assessment.
Thank you. Natalia, do you want to come?
Thank you.
Thank you.
Can I just add one more thing? Sorry,
Yes.
Chairman. So the other thing that we've asked our staff to do is, we're running more operating lists and indeed outpatient clinics now. So we're running clinics in the evenings and we're running clinics at the weekends as well. You know, I don't want anybody to think we're not absolutely committed to trying to do our very best to treat as many patients as we possibly can. We absolutely are.
Thank you. Check now, please.
Thank you. On page 19, it refers to the number of patients seen from GPs with GP referral within 2 weeks. North West London is showing highest. What is unique about North West London that is driving this growth? Particularly on pages 28 and 29, it does show the green line arrow. But if I'm not mistaken, that the uptake is.
Thank you. To go back to the first question, that is performance. So that is North West London actually is performing better.
What is it particularly unique about that?
So part of it is honestly. So I think trying to share risk between us all, a real commitment from clinicians and how we organise ourselves to try and make sure that. And that's not me saying that others aren't doing that. I think to be fair to all of my colleagues across London, there is a real commitment to doing this. But I think the collaborative nature of working, which got much better actually during the pandemic, I think that's really helped us in terms of our understanding. I meet with the chief operating officers of all 4 trusts on a Friday morning, and indeed with our colleagues at Royal Master Partners around this particular subject. And also we look in detail about where we might not be able to meet that and what we need to do together to try and get as close as possible. But I think that commitment to putting aside, if you like, some of the organisational differences that were in place and working together to ensure we see as many patients as possible has been behind that, I think. And I would absolutely say tribute to my clinical colleagues and my operational colleagues, and actually the support that you get from the ICS to be able to do that. We've worked really, really hard.
What is unique about Harrow? Is it the same sort of the green line is it's the highest line? Is that growth?
Yeah, so it's an interesting one. I mean, I think it's an interesting question. We ought to go away and think about it a bit more clearly about why that is, because one of the things that we're trying to get to is understanding all the nuances and all the differences and trying to answer those questions, because that might help us. In another area to try and get
some feedback on that on behalf of Harrow.
Will do. Absolutely. Thank you.
Thank you for that. Lucy, please.
I just want to go to the ETL growth on pages 14 and 15 and understand firstly why North West London is higher than other London STPs, and then sort of with my Kensington Chelsea hat on, why Chelsea and Westminster is 12%, which seems significantly higher than other neighbouring hospitals, and just wanted to understand a bit more about that, and if there is a reason as to why this is just a 3-month as opposed to looking at slightly longer.
So actually, I mean, we obviously do have the data for long in which we can spike. To the particular interest in my own hospital, so vast bulk of that is dermatology. We know dermatology Actually, during the pandemic, there were far less referrals for dermatology, and Chelwest happens to run the biggest dermatology provision. So at least that in part, and we're concentrating really hard on the address of that. I think you heard me say earlier that we have seen the biggest increase in referrals in North West London, so it's nearly 5%. I think it's nearly 5% increase in referrals. And that speaks actually to the amount of extra that our GPs are doing as well, that is meeting the demand. I think there's more work for us to do. I mean, Rob might want to come in, but I do think there's more work for us to do, which is, this may be a good thing. This may be a good thing that says, actually, particularly in some of our deprived areas, more people are coming forward. So I think there is something that says we need to really get to the bottom of this, because if it is a good thing, then and they are appropriate, and that's a piece of work we need to do as well, then I think that's a good and exciting thing. We need to encourage a bit more of it. But I think the piece of work that gets right underneath why that is and explains all of it, and there are multiple reasons, it is something that I know the MCX are spending some time on.
Sure, Rob, thank you. But I wonder if you look at the page 14, Leslie and Rob, sure, I get it that perhaps our GPs are, working incredibly hard, but I'm sure that must be the case in NCL, and I'm sure that must be the case elsewhere in London as well.
Yeah.
What is it particularly? They may be other factors, but I'm just trying to understand what those factors are, which makes NWL that much more out of sync with our neighbours.
I'll try and cut it. It's all said within the context, as Leslie has highlighted, that in terms of the North West London performance on long waiters, so we've eliminated 2-year waiters, we're on track to get to 78. So what we're talking about here is the size of the overall waiting is not the length of wait, and the length of wait, the long waiters has been coming down, continues to come down. Continue that to eliminate 1-year waits or 18-month waits, etc. over the time. Notwithstanding that, this clearly provides additional pressure into that. And certainly, going back to my North Central London days, we were very concerned about what we call Project Iceberg, which is the unmet need that we had in our communities that was not being referred in, and we were worried about the fall off in referral levels during the course of the pandemic. So that's why potentially, as Leslie says, it's good news, because we're actually exposing the level of need that we've got in the interface between that. To work with our GPs on appropriate referrals, yes, but at the same time, it's better that we're reviewing the appropriateness of referrals than it is that we're not capturing the unmet need that we've got there. So I think we've got that factor. I think we have got a number of different things that we've been doing in the NHS and in North West London. So bringing in new advice and guidance services, bringing in new ways of accessing primary care. To review on a whole range of it. So we're up to 2/3 our face-to-face contacts, 140% of where we're going through GPs and primary care. So that extremely high level of interaction is going to lead to more identification of issues. And so I can't prove it in terms of why that means we've got more than others, but we're certainly doing a lot of work to make sure that we are bringing out the need in primary care and referrals through, and the need to respond to that. Work to do on appropriateness of referrals, as Leslie says, in terms of making sure we're not duplicating. We've got different records on our waiting list, things appearing twice, that our clinical advice and guidance services are not creating erroneous indicators of actual need. And that means that an element of it, I am sure, is a tidying up of new processes that's actually not.
That's going to be real for the others as well.
Yeah. Sorry, but the extent to which clinical advice and guidance has been implemented in North West London is one of the highest in the country in terms of these new models. So the range of attempts to try new ways of doing things were at quite a high level relative to our peers across London.
Thank you. Okay, take that, please.
I wanted to ask about breast screening campaign and health promotion, specifically target minority communities, and also those that might not be in the normal 50 to 70 age bracket. breast screening? And, what targets on that specific, anything specific?
Hi, it's Sanjeet here. Good morning, everybody. I probably can. I might just ask you to repeat that question. Sorry, it's a bit. It's not very clear coming through on MS Teams. Sorry, could you repeat that again, Chetna?
Now, if I speak can you hear me?
That's much better. Yes, thank you.
So, with regards to breast screening campaign and health promotion models, specifically targeting, newly arrived communities or other communities, and those that are not between the 50 to 70% age range, the younger people,
Yes.
what campaigns are being targeted?
Yeah, so that's a good question. So in particular, because we know that we do want to get more of the young target, some of our campaigns towards the younger, particularly women who are approaching the age of 50 as well, but also daughters of women who are in between the ages of 50 to 70 to do some targeted work around breast screening, raising the awareness, what to look for in terms of symptoms. And it's not just about educating people on how to access, it's how to recognise symptoms as well. So when we're doing campaigns, it's not just targeted at the 50 to 70-year-olds, but it's also at that kind of the younger women as well, because it's not educating them either. It's also about them using that information, obviously, to encourage their aunties, their mothers to actually come forward as well. So in any campaigns that we're doing across London, and particularly in Northwest London, they're part of that scope, within that scope as well of that group. Obviously, we are doing specific work at the moment around the 50 to 70-year-olds, but also women who've never come forward for their first invites, because we know that women who don't come forward for their first invite are less likely to come back for subsequent screening appointments. So there are target audiences that we are kind of focusing our efforts on first, particularly the non-responders, the first-time invitees, but certainly the women are equally. If we get those messages out to women at a younger age, that definitely makes a difference as well, and they can also cascade those messages onto to relatives as well. So no, that's a good point, and that's definitely within the scope of the work that we're doing.
Thank you.
Can I ask specifically what campaigns are currently running or are being forecast?
So we work with community links. So we, as NHS London, we commission the 6 services in London to deliver breast screening services. As part of that delivery, we've got cancer alliances as well, and we've got breast screening services working with independent organisations such as like Community Linked, who will actually directly contact. They will telephone those non-attenders and we know from the evidence base that that does make an impact in terms of women then coming forward. So there's targeted work going on there. There's obviously work going on, particular faith groups going into, this is across London, this is not just specific to Northwest London, working with South Asian communities as well, going into temples, mosques as well, to have those conversations with Black communities as well. So there's targeted work, and I know Imperial West of London Breast Screening Service, who deliver across 7 of the 8 boroughs in London, they're already doing that. They're going into schools. I know you mentioned about young women as well, and girls as well. They're going into temples, faith institutions, using community leaders to kind of champion breast screening, the importance of coming forward, having regular screening. So there's multiple kind of targeted interventions going on across, because obviously we recognise that depending on some of the communities, we do need to nuance our approaches. So it's not a one size fits all, but very much locally led. That's what's making the impact. There's much more that we can do. We're very aware in London that our uptake is not where it needs to be. But there are things happening at the moment, and this ramping up. We've not been. Just one final point. Sorry. We've been in a difficult situation, breast screening, because of capacity and workforce shortages. So we've been very mindful that we can't do a full big bang targeted campaigns, because we need to make sure there's enough capacity to see women as well. So we are going to be ramping up some of those activities over the next few months. Sorry, I've gone over my time. I know I've only got limited time.
Everybody, Sanjit, you're doing some amazing work, and thank you very much for sharing all of that. I'm keen to understand a little bit around the actual take-up. So with all that fantastic, wonderful work that you're doing, what is the uptake? Because looking at the report, I see that the uptake, in fact, has fallen as we come out of the pandemic. And if you're doing all this amazing work, what do you think that is?
So the uptake has dropped in London. I think we need to
I would be
recognise.
appreciated. A favorite like this. A favorite like to be appreciated.
I think the open invitation methodology has impacted London's uptake levels. That's why we've seen a substantial reduction in our uptake levels compared to other regions. So there are a couple of things that did make a difference during the pandemic that impacted our uptake more than other regions. Hence why we are coming from a lower baseline. But we are recovering now slowly. It's going towards, it's an upward trajectory now. We think in about 12 months time we'll be there. We'll probably get back to 60% uptake. And those are through the interventions that we're doing. There's so much more we can do. It's not where we want it to be, but we are being ambitious. 70% is the optimal standard, and that's what we'll be aiming for in London.
Thank you. Natalia, please.
Thank you very much, and thank you, Sandy, for the report. I have a question about the target work that you're doing. And is it more looking at supporting women that have got the symptoms, or do you have the resources to also explore gene testing for breast cancer? So in women and girls who within their family, they may have an old woman that has sadly had cancer or has passed away, and genetically they may have a tendency to develop it. Are there systems in place to try and trace that?
Yes.
Thank you. And again, sir, don't want to be rude, but a quick like this.
There is a specific pathway for very high risk women, so they don't go through the routine screening route. So there's a dedicated pathway. But I'm happy to take questions offline. Please, you've got my contact details. Please email me if you've got more questions. I'm happy to have a discussion offline with you.
Thank you very much. Thank you very much. Just one final question to you, Leslie and Rob. Rob, you was talking about being, in earlier reply, need to be responsive and how you are, being responsive. And I just wanted to understand the role played by RM partners to help you in being that responsive and how much is that having an impact, particularly in tackling the health inequalities, perhaps amongst some of our residents with learning disabilities, autism, and stuff like that, please?
So actually, it's one of the things we talk about all the time. So RM Partners helps bring together all of the intelligence in a way that Sanjit just talked about, actually where we are in deficit in terms of some of the populations that we don't get to, and actually helps us design the campaigns in the way that Sanjit just said, to get to those individuals. So be they in at home or in residential settings, all of those things are something that we haven't been good enough at it. We're still not good enough at it, but those are the sorts of areas that we're working on.
Just build on that. So I think one of the reasons why North West London has good performance relative to others is the Royal Marsden Partnership Cancer Alliance, which is, in my experience, very effective bringing together of multiple issues as opposed to, because it's a complex pathway, isn't it? It's many different aspects to the cancer services that need to be coordinated. It's point number one. Point number two, inequalities and differential access impact is, number one on our agenda in terms of Royal Marsden Partners are leading the way in terms of their analysis of the different impacts.
And all of this is helping to reduce the backlog.
Yes. So there's
this is actual, reduction in the right direction.
Yes, there's more to do in terms of that, but we have to keep an eye on inequalities alongside the number volumes as well. So it's a dual effort to marry those two things together rather than to have a numbers backlog and an increase in inequality.
So I guess that talks to, do we mind about the numbers going on to the waiting list increasing? And if that's the right thing to do, we want to encourage it. We want more people to come forward. And if that means we've got to work harder and find different ways of working, then that's what we're committed to doing.
Okay, thank you. Very, very final point from Dan, please.
Yeah, it's just my colleagues from Hanwell will shoot me return to the evening. So at least asking you, whoever it is who can answer about a specific backlog in relation to Hanwell Medical Centre and those local issues, notwithstanding the comments that everybody has made in regards to the absolute importance of this work. And I would just say, yes, it's great that we've got more people coming forward, but that presents a future challenge for the NHS, as I think Councillor Halai has mentioned in her earlier questioning. If we are not able currently to meet the backlog between the 4 women aged between 50 and 70, how are we going to persuade those younger women that we always have great difficulty in persuading to come for their first set of breast screenings?
Thank you.
To do it. Sorry.
Thank you very much. A quick point, please.
I'd say there's more work to do. I mean, in terms of the specifics of Hanwell, I think that's a fair challenge in terms of our approach there. Sanjay, we won't ask you to do it now, but I think we'll take it offline.
Perhaps I'll send an email on that.
We'll want to that.
Yes. Thank you very much.
Thank you, Sanjay, and thank you, Leslie and Rob. Before we move forward to the next item, colleagues, are there any recommendations that we would like to make to our NHS colleagues? Chetna and then Chetna, please.
We share best practices as to what's happening in Harrow and North West London, and share that with other boroughs and across other regions.
Thank you very much.
Can we get the data on that?
Yes, thank you very much for that, Chetna. Dan, please.
Yeah, I don't know that colleagues will agree with me this, so I'll leave it open to them. But I wonder, there are a lot of discussions now across a number of agencies. We've heard about some of them today. I wonder, with so much of this sitting in the local authority space, in the broader public health scheme work and that collaboration, and the things we've learned from the pandemic, are there things that local councils, local councillors, community leaders can amplify in this space that supports you in this work, particularly if so many more people are trying to present it? Is there something that we can, or that you can feed into us, that we can then feed back into communities? Perhaps we could, by right to you, Chair, when we share some things on email, we could send some messages around.
Yeah.
Thank you very much. I can see all the 3 colleagues nodding their heads in affirmative. So thank you very much, including our 4th colleague on the screen. Thank you very much to all of you. So Sanjit, you're free to leave, but you're equally free to remain.
Yeah, will do. Thank you. Thanks. Bye-bye.
Thank you. So our next paper is winter planning, and Leslie, you're going to be presenting this paper again, I see, and it'd be helpful again if you spend 2-3 minutes just drawing out the key points, and so we have the maximum time for the questions and answers, please.
So thank you. So as well as being Chief Executive of Chelsea and Westminster, just in the context of this, I'm also the NHS National Lead for Discharge and Flow. And of course, our ability to be able to run our hospitals and indeed all of our services as efficiently as possible speaks to flow, which I'm sure we will get on to. So in terms of the winter plan, our ICS and indeed all of our colleagues across each bit of the system, so primary care, the acute units, our community mental health units, and indeed in discussion with our colleagues in local authority social care specifically, have joined together to bring together our winter plan in terms of how we increase the numbers of services that we've got, how we increase the interoperability, so the working together of all of those services between primary and urgent care in particular, and in terms of the planning for patients being in the right place at the right time. So there is, again, no surprise that all hospitals, in particular across the country, have been challenged by the amount of urgent and emergency care that has come forward. Rob talked earlier about the increase in numbers in primary care. So it isn't that actually there's a deficit in the way that our primary care colleagues have been working, but there are increasing numbers of patients who have been coming forward for emergency care, and you will have seen played out in the press the some of the challenges for our local for our ambulance services. What I would say is in London and indeed in North West London, again the performance is reasonably good, and we have how we meet that increased demand. But I can't pretend that it isn't challenging. And what we have tried to do in this planning is to plan to meet that emergency and urgent demand, as well as trying to minimise the impact on the elective recovery that we've just talked about. Because, of course, one of the dangers of increased number of admissions from emergencies is that actually that results in some of the cancellations of elective care. So we've tried to plan in a way that does protect the elective pathway as much as possible. A few things that are of course testing for us at the moment. So we've got a reasonably stable but a little bit of increase in COVID. We've got an increase in flu. And indeed, you will have seen that strep A in children is causing.
Very good questions for the ICS updates.
Yeah, yes. So sorry, I'll stop then.
Thank you.
I can do your update as well.
Indeed.
I'm turning into Sanjeev. Right, that's it.
Thank you very much. Thank you. So, unsurprisingly, we have got many questions. And again, I would ask if the replies can be as succinct and as focused as possible, so I can get through all the questions without having to come back to you with written questions. So let me take Chetna first, please. Chetna?
So my first observation on page 31 is I've noted an extra £3 million, which has been identified for funding this winter. I'm not clear on how this extra £3 million specifically going to be used. Which services, which departments? Is it going to be addressing backlog in certain departments or recruitment or other aspects of the nature?
Thank you, Chetna. Rob, please.
So it's all part of, it's contained within our 15 million winter plan funding, of which we received some additional external. The 3 million was particularly identified locally in that we would look like we would have some scope in this year to focus some resources from within East West London into this, and that was agreed with the wider system. So it's not a different set of things that's being spent on. It's the same things. Everything that's being described here is included within that. So we have two major pots of additional money for winter. One is the 50 million, of which 12 comes from has come from nationally. 3 we've identified locally. Given where we are in the year and we're forecasting for this, can we still hit our targets for the year? We found that 3 million. And secondly, the 16 million, of which 60% has come through us and 40% directly through local authorities, but 60% through the ICB, the health service, will be passed on through Better Care Fund into discharges. And that, again, has a whole list of schemes agreed with partnership authorities. So these are not different initiatives to those described. I'm not sure if that answers the question.
What specific, how is it specifically going to be used?
So the whole pot,
just a general.
The whole pot is in creating additional capacity in community beds. It's creating additional capacity in care homes. It's creating additional capacity, additional inpatient bed capacity for patients to stay in who are currently in hospital. Because these hospitals are currently very overloaded with patients who are medically optimised.
But Robert, that port is going to be spread right across Northwest.
Completely. So
in a uniform way.
Yes. So there's a list of schemes by borough. There's have been, so the criteria that have been applied is it going to create extra capacity? Is it going to have impact on ensuring that patients are flowing through the system, so that we're not continuing with as far as possible the situation we have with ambulance waits, that we have evidence that it's going to be effective. I'm afraid in my mind I've got a whole list of about 100 different schemes, so it's quite difficult. I'm very happy to provide the information more detail.
Thank you for that, General Sofa. Let me just bring
the important message here is, so this is money that says we want our acute units to be able to answer the front door, to offload our ambulances, and we want them to do the elective recovery. That's what we want them to do. And in order to do that, we need to have patients in hospital that only need to be in hospital. At the moment, we have good numbers into the hundreds of patients across North West London who actually are not receiving therapeutic care because they're in an acute hospital. So our dementia patients, that is not a therapeutic environment, we could name them. And so this money is to start to I think, support all services, including our local authority social services, that says, how do we address some of the funding gap and indeed the workforce gap that we've got in local authority social services care and in other bits of the system. The really important message here is we need to be able to demonstrate this has an impact, because that is what will allow the embedding and the recurrent nature of that funding. You've got to demonstrate that it actually works.
And how are you going to do that?
Well, so I could, if you don't mind me saying, I could slightly turn that question around, which is how. So that is a question, and in fact, we've got a meeting with Bernie Madas from here actually tomorrow, which is, so what is it that we will need to be able to demonstrate in our local authority social services? We'll need to demonstrate that will allow particularly that money to be recurrent for them. That's the aim of a lot of this from us.
We, the ICB, are going to be measured. I mean, Leslie's a national lead on this, as you know. But the additional money delivers an increased number of discharges, a reduction in the length of stay in hospital for categories of patients that we currently have, and moving patients through to more appropriate settings. And there's a specific set of targets, trajectory improvements that we're needing to bring in over winter as a direct result of that money, and that requires partnership with our local authority partners to deliver.
So there is evolving strategy, or there is already one in place, and you're working through that, or you're putting something together.
So where we are today is we have 5 boroughs have submitted plans, which we're running through. We've got another 3 boroughs still to come through, that we're expecting those to have the improvement directories that the national team are expecting us to make. We need to review those.
What's the timeline for that?
So that's happening this week, as we speak. National
submission is December 13th.
13th is the national submission.
Yeah.
You're very welcome to share those. We're very happy to share those plans by borough with you.
Thank you very much. Let me check now, and then Lucy, and then Marina.
Comments you both made on the discharge. Increasing discharges is great, optimizing. But what about community care after certain vulnerable or adults have been discharged? Are they going to receive the support that they need? Are the resources there to help them? And also, wait times for ambulances is under 60 minutes.
So before you come in, Rob, let me just, Marina, did you just want to take your question, because I think it's similar to Jetna's?
Yeah, it is. I was just going to say that sort of like discharging back into the community, then there is a staff shortage on community workers. So how is that going to be implemented in a timely fashion if there is no staff to be able to provide the care?
Thank you.
I could give you a national. So there is I guess what we asked for, what we and in a way campaign for this money to do is to start being able to improve that. What we've got to do is imperfect, and that we've been able to deliver it, but to show some trajectory of improvement. And if we can do that, if we can demonstrate that actually wages, or we've done however we've managed the market, in this case in North West London, actually that demonstrates an improvement that will allow the argument that says, and actually allow us to embed. We can't do these things in 5 minutes, is the point you made. So if we can demonstrate some of that improvement, I think will invigorate the discussion that says our local authority social services will do good stuff, but we need to fund that good stuff. Actually, we need to fund it not one-off, but on a recurrent basis, and that's the basis. In terms of the second part of that transformation, I think it's a really important question that says, in terms of a transformation of patients, we know that particularly elderly, there are various groups of patients, but particularly elderly patients deteriorate in hospital. If you've got dementia, you've got a buzzer going non-stop, and you're in a strange environment, you deteriorate. That's what happens. we need to work very hard to look after those patients in a much kinder environment. But to enable us to do that, health also needs to be able to provide some of the technical, if you like, the healthcare into our nursing and residential homes and into domiciliary care to top up some of that care. So that's why that plan needs to be brought together to enable us to make much better use of our overall resources. So I think that's the plan. That's what the ICS are working on.
Thank you. I bring Lucy. Thank you, Lucy.
I just wanted to talk to you about the annual funding for mental health that has been added to this report. And I mean, I know you're opening centres like the Crisis Centre in St Charles, but just more generally in North West London, what that funding will be going towards. And then on a slightly separate note, the mental health support you're actually supplying to doctors and people who are working with the NHS, just because I think that's an aspect that is going to affect churn and recruitment and lots of different factors.
Thank you, Lucy.
I'm very happy to say that. So clearly, in addition to the mental health investment standard, the increased investment in mental health services that we've honoured, the schemes that we're talking about here do include additional beds. They include, you've mentioned the crisis centres, they're not directly funded from this, but there is additional and new models of care in mental health that we've been putting in place for this winter. There's particularly around providing appropriate therapeutic settings, that the transfer through a hospital A&E department and into an acute is not always the best route for mental health patients. So that's why those crisis centres are being set up, while we have new models with London Ambulance Service. We transfer patients to the most appropriate setting that's being brought in. So this money includes investment in mental health services to achieve the overall aim of appropriate flow to the right place within it. So it's attempting to be equitable across boroughs. It's attempting to be equitable across individual component parts of conditions for patients, with an overall gain to flow and therefore reducing clinical harm risk caused by delays in ambulances and other access to other services.
The health and wellbeing question.
I'm sorry.
In terms of just employees of the NHS, I think
So I can say. So I think actually, I think possibly for GPs more in terms of our provider units where we've got thousands of staff, and that's not just acute. That is our mental health and our community units. So with Rob, actually, we meet about weekly, if not every day. But actually, we've put a pretty good health and wellbeing offer in to staff, including access to, wouldn't call it IAPT, but IAPT type therapies, but other things around supporting them in many ways, childcare, and many ways. GPs, I think it's reasonable to say we possibly could do more.
Yeah, it's harder with the GPs in terms of we offer occupational health support packages. We're offering a service, but in terms of relative to a hospital where you've got a sort of specific campaign around that.
Employ them as well as the
directly employ them, but there are support wellbeing offers, psychological wellbeing offers available for general practice, occupational health services, referral routes into support mechanisms for.
Charlie, please.
Thank you very much. I mean, you've alluded already, but Strep A is on the news.
Yeah.
So what impact can we have in terms of the plans that you have ahead? I know that this funding is to respond to pressures.
Yeah.
And this is a new emerging pressure. So
Strep A is an infection that we have it every year, actually. And of course, children, as we've seen, can be vulnerable, very vulnerable. But of course, what we know this year is that last year and the year before, they weren't at school, they weren't having all the mixing that would be normal part of the normal spread and the normal building up of immunity. So that's why we've got the issues that we've got. So I think in this case, the government and health authority have done a good campaign in a way, because we can see from the numbers of children coming either into primary care and into the urgent and the emergency centres, there's an increase. And in a way, that's fine. That's what, you know, if you're worried, then we want to see that child. The vast majority of those children will have a normal respiratory illness or normal chest infection or sore throat. But if we can, we want to pick up very quickly, because actually children become very unwell very quickly. They get better very quickly, actually, but they become very unwell very quickly. So we do need to see them. So the best thing we can do is to encourage our parents that if you're concerned, let's see the child.
Is it work around a campaign, communication?
I would say,
And I think
looking at the
there's
numbers.
I think there's a much bigger point around communication.
Yeah.
And engagement. So I think, Natalia, if I can just build on your point, and Rory, you might want to come in here as well. I just wonder what work is happening on ground to have that joint message. So we heard the work happening around ambulance and discharge. We are now embarking, on a conversation. Thanks to the last question around primary care, and I just wonder how are we communicating that message to the community to ensure that our systems aren't overloaded, and it means that there are many more ambulances waiting and many more people waiting to be discharged and many more people waiting for appointments and so on.
So I'll start. I just want to start because it's a very live issue, isn't it? Here and now today, we are trying to work with regional and national colleagues on the messaging, and we need to get some local key messaging going on that. And Roy will advise you on this. I think this is a critical issue at the moment. But to respond to the general point, we have made ourselves as fighting fit, resilient as we were able to with the winter funding, the plans, and this event would not have changed how we would have applied to that. We did have investments in primary care. I talked earlier about the additional slots that are available throughout winter, how we're using 111, a whole host of things I won't go into detail on to increase our winter resilience to cope with exactly this scenario. But you're absolutely right that the current communications we could do with a lot of help on, and how we're actually going to do more on that locally now and throughout the winter.
So that has started to happen. So we're working with our local authority colleagues. All the national information, the briefing, the Q&As and things have been shared with council comms. There's a letter going out to schools, I think, today to advise parents on symptoms to look out for and what to do. And there's a lot of social media activity as well, and it's picked up as part of our outreach engagement. So it's a campaign.
Good, thank you for that. Marina, please.
Just a quick one. For those of us that know that this is annual, it happens every year, and obviously because of lockdown and children not mixing, that's why it's more prevalent. Is there any reason why in previous years it wasn't called strep A? It was your scarlet fever, it was your vertigo, it was your throat infection. Why is it being called strep A? Because from what I'm seeing on social media and community groups, it's the technical name causing the fear.
That's really a valid question, and I think, of course, for us, we've seen children die of strep A infection, and that's where this came from. Was so locally we've had a child die. We didn't know quite why, and then when the swab comes back and it says strep A, so for us that was a strep A thing. And I think what's happened is, unfortunately, I think it's a really good question, and probably we need to do some work around what this is. Is that the media heard what we were saying in terms of these deaths. Now, the bit we don't quite know yet is will these deaths form part of what is a normal number overall? And there's been it's patch. We're not sure yet. It's just too early. But I think it's a really good question that says, how do we reset that? That says this is. These are our normal childhood illnesses, but just look out for them in the way that you would and bring them to see whoever you want to see.
Okay.
Yeah.
All right.
What we're seeing at the hospital, it's overloaded and it's queuing around the block.
It just causes unnecessary winter pressures.
Yeah.
We didn't have that.
So the only other thing I say is one of the other bits of communication is there are many people. If you walk down the no, we're not. We haven't got Chelsea at the bottom of the road. But if you walk into the local hospitals, there remains people in those urgent care centres and ED. I'll give you an example. A group, I have a teenager the other night eating a pizza in our waiting area because they'd had a bee sting, and you just think, seriously, but so that I guess there's another thing that says if you do that, people that we need to see very quickly, because you will go onto that 4-hour wait, people that we need to see very quickly may be displaced, and I think that is something we need to refine our discussion.
Chetan, please.
Can I ask about what actions are being taken across North West London to mitigate the effects of any strikes by NHS?
Thank you, Chetan.
So obviously, we have, like in all our scenario planning, emergency planning scenarios, and incident planning, we have set up mechanisms to make sure that we are planning for the dates ahead, the industrial action. There's a London-wide group. There is individual organisations have developed contingency plans and individual sort of proposals around how they're going to keep the urgent care services going during that period, working with London Ambulance Service as well on their contingency plan. So the actions are for each organisation has an agreed contingency plan to cope with the scenario of anticipated staff absences on the days of the strike, and that we as a system review that, and the London region review it with us and the national team. So
thank you. I think it'd be good for us to have an assurance that it is not going to pile up even more pressures for any of our.
I don't think anybody can say it's not pile up additional pressure, because self-evidently we won't be doing as much activity in that scenario than elsewhere. What we will be keeping is urgent services going. And
well, to be clear, as we stand now, only one of the acute units actually has got strike, and already mutual aid has been offered from all the issue. The bigger issue actually is the transport strikes and people being able to get into people getting into to work.
I think that's a very important point. At any given time we have absences caused from a whole host of reasons, so we're not unused to dealing with events like this.
Thank you very much. Let me bring Dan in for a final point, please, Dan.
Yeah, so I think there's really encouraging work here going on. It's just about where we as colleagues add value to the work that's ongoing. We're always talking to so how long will I set it at this, and Councillor Shed goes on. And saying as well is there's an opportunity for councillors to play a role as community leaders in our engagement, as Councillor Sharma, Councillor Nye, Councillor Brez already outlined, and Councillor Knight earlier on. The role of local authorities is vast. The opportunity for people to feed in and speak to us in a way that would therefore prevent, as Councillor Sharma was identifying, people turning up. I would just say industrial action is a concern. We know that the three of you are not responsible for the planning conditions and the ongoing problems, and if only we were, we wouldn't have these issues.
Can we comment on that?
I'm not. Notice I didn't ask you to. But I do think that whether it has an impact on the front line, and it will undoubtedly, it will flow through to the other parts of the health service, to wider health inequalities. Some people will be more able not just to get to work, but to access health services. And I would, maybe my colleagues would disagree, but I think it is an appropriate point for the committee to recognise the selfless service of our NHS staff and all of our health workers, not just at this time, but throughout the year.
Thank you very much. Thank you very much for that, Dan. I'm grateful to you. Any recommendations arising from our discussion, colleagues?
So just a plea, really.
Yes.
In respect of recognising the role that we can all play together and collectively. I do see the opportunity for something I think perhaps the opportunity with the ICS being set up with this more regionalised focus that is certainly the ethos behind these recent changes. It allows us to do more about tackling the inequality and in many forms. And Rory wants to
Thank
have
you.
it, so I'm going to let.
Yeah, I was only going to say we're already working. But questions have been brilliant. The talks today. But if councillors want to get directly involved, that'd be really helpful. So
Great.
I'm very happy to.
Thank you very much. Thank you very much. Yes, Chetna.
We've just committee seems relevant, going back to the earlier point on how the finances are used and justifying how they're used, so you can get additional funds going forward. We talked about that, maybe getting some report to support future. Yes.
So I think you agreed to share that information with us.
Very helpful, and specifically on the point. So I think in terms of the use of this money during this winter will be instrumental in winning the case for next year and beyond funding. So
Not just the allocation, but you know, the outcomes that that allocation is going to deliver.
the money having
Exactly.
will give us a good cause for the continuation of additional monies next year.
The chair just also certainly not to track many of the points that are made. I do think this is the whole reason why you've got the IC, why the NHS has adopted the ICS approach. And we're clearly, there is a finite amount of money and resource that is going to be put in this area. But we do have the opportunity, both at the local level as local boroughs and as in public health space, to identify best practice and to expand on it. And to learn from those areas. So more information about what is currently being done, what is being planned, and if it's shared more widely than just with our comms team, but with us as.
Okay. Thank you. So George has very helpfully noted down all of that, and we'll take that offline. Thank you very much for that. So we will make progress now to the next item, and very happy to say that we've got Claire Murdoch and I think Charlotte Bailey with us this morning. And good morning to you both, ladies. So the next paper is North West London Workforce Strategy. Claire, Charlotte, I assume you're going to be doing a double act. We have seen your very attractive looking slides. Thank you for those slides. I wonder if you could spend 2 or 3 minutes giving us the key headlines from those slides, please, before we move to questions and answers.
Yes, thank you very much, and thank you for asking us to attend. And apologies we're not attending in person. Charlotte Bailey and I have just stepped out of a board meeting to join this board. Otherwise, we would have been there in person. And we also have Lindsay with us this morning, who does a great deal of work on workforce. So we should be able to answer your questions in detail. I think the main thing that we're wanting to bring to JOSC today is an overview of what our work strategy and work plan is and our approach to workforce, a brief overview of some of the challenges which frankly I think we're all only too aware of, but very importantly some very concrete actions around the things that we're actually doing that will make a difference. We wanted to add briefly, I suppose, a brief item on the industrial action and winter. So although we're trying to take a medium long-term view, because this is all about retention, recruitment and workforce development, we know we've got a very challenging few months to get through. So we're trying to give you a flavour of both of those things. I'd like to say a couple of things and then hand over to Charlotte. So we do work towards our strategy. Key in all of this are partnerships. We're doing some great work with local authority colleagues, job centres, charitable organisations that, for example, represent refugees and how we get them into work. We've had a super event just recently where we've offered jobs to more than 200 refugees seeking work in the area. We absolutely are exploring and taking seriously our anchor institution responsibilities. We're looking at joining the NHS and the care system easier. So I know our acute collaborative colleagues, I was talking to Pippa Nightingale only this morning, have recently offered some 400 plus healthcare assistant roles, health and care roles. And they did that work working together, but very much with local authorities. So I suppose I want to really emphasise that we're doing some innovative things, trying to draw workforce through different channels. I know in the provider collaborative, we didn't require people, the acute collaborative, we didn't require people to fill in long application forms before we saw them, because we know for some with great talent and an ability to make a contribution, filling out an application form can put you off at the very first hurdle. So we're trying to really innovate, whether it's around the process and partnership and how we recruit, who we and the development of new roles. I think just on winter and industrial action, if I might very briefly, because I'm not sure if that slide was included in your pack, clearly all organisations across the sector have been making plans for winter, looking at, if you like, broadly 3 options across the spectrum for just how challenging winter will be. Everything at the furthest end, looking at if the worst happens, what are the things we will do? Sorry, Rob, do you want me to stop?
I've already covered that, Claire, so
Oh,
thank you.
okay, so sorry, so you can stop me there. And have you covered industrial action as well?
Yeah. Yes, I have. Yes. If there is a question, we'll bring you back in, Claire.
Lovely. Thank you very much. I think the key thing I would just say on industrial action, talking to Tim Orchard this morning, is as well as the logistics, Imperial and other partners are paying great attention to culture and staff relationships, right to strike, right not to strike. And he was keen that I raised the fact here that we all are very concerned about the transport and rail strikes. So we're looking at how we support our workforce through that. So I've probably said enough and you want to get to questions, because we're doing a great deal of work in this space.
So I don't know, Claire, I don't know. I think it's the gremlins in the system. I don't know if you can hear me. I'm hoping that you can hear me.
Yes.
Charlotte, did you want to add anything further to what we've just heard from Claire?
No, I think move to questions. Claire's given a lovely overview there.
Thank you very much for that, both of you. Okay, so let me bring very quickly Dan in. Dan?
Yeah, thank you, and good morning or good afternoon. It's still morning, I think. Thank you for travelling between your various commitments, both of you, to join us. Your workforce priorities, I think, would be welcomed by the whole committee. We've spoken about this here previously. One of the things I wanted to ask was about the role for attracting sort of longer term unemployed people into the NHS. I know that's a priority, having spoken to colleagues over a long period of time. And I think there is a role for local authorities to add value here through our apprenticeship schemes, through our work with partners, and 2 particular partners in West London, Action West London and the Shaw Trust.
Yes.
And you're nodding, so
yes.
I'm some work with all of those organisations. I just wondered if you could summarise briefly where we are and where local authorities might add value, because we can go back and talk to our colleagues. If they are not talking to you about where we can add value, then we'd like to facilitate that conversation.
Thank you. Claire?
Yeah, well, firstly, thank you for that. And we are cited on the work of the Shaw Trust, working with local authorities around job centres and how we fast track applicants into health, how we remove the barriers between us so that we can go on framework, but remove some of the things that perhaps put people off of applying for a job if they think they haven't got the qualifications, or they've been unemployed for a long time, or potentially they've had a serious mental health problem or other disability as well. So I think we're really focused on the removal of barriers and fast tracking people through to possible jobs in health and care through working with the local authority. So I think it's a pivotal partnership, which was why I started there. I think as well we're doing some really great work with, for example, care leavers. We're working closely with local authorities about, can we set up more internships? How do we get people into work who traditionally have found it hard to access the world of work and yet have great skills? Charlotte, would you like to add something there?
Yeah, just to say a number of pieces of the work we're doing, particularly with social care. We've now mobilised the Health and Social Care Academy, which has brought together a partnership of our HEIs, our job brokers locally, and links from within local authorities. to be able to look at recruitment from our local communities and to take them through learning, education and training into pathways and careers in NHS and social care and primary care. We've set a target of 2,500 learners by 2025, and we've already mobilised around about 300, and they're all from those backgrounds that you're talking about. We've also got some very specific pieces of work happening in dedicated local authority areas. For example, in Brent, we're doing some joint work with their graduate scheme and on the Social Care Academy. And we've also very recently set up an interface meeting between the local authority HRDs and the NHS HRDs to look at how we can maximise that even more. And then also our vaccination to vocation was people from our local communities. We're currently over target and we've retained 349 of those people from our communities into our organisation. So there's a number of pieces of work, but it's focused on the Skills Academy as our main sort of point of interface, really.
Thank you, Charlotte. Just for the benefit of the viewers who may be listening to this, HRD stands for?
Human Resource Directors.
Thank you very much for that. Let me just bring Natalia in, and then I'll bring the other colleagues in. Natalia first.
Thank you, Chair, and thank you, Claire, and thank you, Charlotte. I hope you can hear me okay. The workforce strategy said that 55.2% of staff are BAME. We also know that racism against BAME staff and patients and colleagues is a problem in the NHS. So my question is, why is this racism not explicitly recognized and addressed in the strategy? Also, how is the NHS race observatory work fitting into the workforce strategy?
Thank you. Thank you for that, Natalia. Claire and Charlotte, please.
Thank you. I mean, we're doing a huge amount of work around equalities, race, racism, both at an individual organisational level, whether that's actually, I know CNWL introduced a Show Racism, the Red Card strategy last week, the week before, and each organisation's doing a lot to tackle racism, but also look at career progression and other things that matter most to staff. So it explicitly is part of what we're doing. And Charlotte, I just wonder if you can say a little bit more there, because it's incredibly important, as you say, and we're very cited on that diversity and staff belonging and feeling good about the organisations they work for and with.
Absolutely. There's two things probably to add there in terms of key pieces of work. One is around sort of the climate and culture. So across our trust, we developed a leadership framework around inclusive and compassionate leadership, and all organisations are embedding that. The second is collectively, we've worked across the system now to set what's called model employer goals. So as you rightly say, 55% of our staff are from Black and minority ethnic backgrounds, but a lower percentage of those are actually in higher grade roles. So we've set ourselves stretch targets across North West London, and we've budded organisations up to support each other. We do sharing best practice events, but we also now report on our data regularly to be able to use that to stimulate improvement, and it's a key focus for us.
So Charlotte, just so that we understand, how frequently is that target monitored, and is there a timeline for that target, please? And is there a date that we hope to have that magic number, perhaps?
Yeah, so we've got an inclusion board. So that's part of a subset of the North West London People Board, which oversees this work on a monthly basis. So it's actively monitored and we report it through into the People Board and the Care Partnership. So we've got the grip on where things are. In terms of the timescale, the model employer goals nationally were set for 2028. We've brought them forward to 2025. So there's targets by year for each trust to make. They're also supported through the oversight meetings that we have as well. So there's lots of support and challenge going on.
Thank you very much. Natalia, please.
Thank you, Chair. Just as a follow-up, and thank you for addressing the questions. I've got a suggestion, and I wonder whether colleagues as well would agree with the suggestion and propose a recommendation.
So we've come towards the end, if that's okay. The recommendation.
I was going to do questions, right?
Yeah.
Okay.
So we'll take that. Did you want to come back? Did you?
No,
Okay, thank you. Now let me bring, did you want to come back?
Yes, I
Claire.
have a question, which was obviously there are big staff shortages which you're addressing and change of roles. I think one of the things is, and I can see everything's being evaluated to get funding reinvested, but it is also that issue of there are places of excellence where new roles are being developed and there is great success. It's sort of how agile are we at then spreading that good practice and making sure that if we found an alternative way of doing things that uses staff that we can actually recruit, how quickly does that get shared and how quickly are we able to roll that out?
Thank you. Charlotte?
Just as a practical example of that, one of the programmes that we were running in North West London around healthcare support workers doing a joint recruitment event. With over 650 offered a job on the day. 49% of those now are in trusts working with a retention programme with them. But rolling out that good practice, the acute group took that forward and have looked at a healthcare assistant programme, which is what Claire alluded to. So when we do something, we take the learning from it really quickly and then look at how we can mobilise it in other areas to maximise what we do. We can do more. We want to set up more good practice events, particularly across health, social care, primary care, which is the space we want to move more into. So we've got plans across the wider care, lead, grow, enable pillars to be able to look at that good practice and extend it and also take it from other areas as well.
Thank you. Chetna, please, and then Lucy.
So supplementary on that, we can see that this North West London is having this specific issue. I'd like to know a little bit more how this compares to other, not North West London, other regions and across nationally as well, and what's working really well there and what we can implement to specifically help North West London, which in London you could say is maybe more condensed, more concentrated, more populated. So where are we not using best practices and developing the workforce strategy? How long are we going to use the argument that it's always times of change? There's always, because of this, because of that. How long are we going to, use that? From what I know, since I joined the NHS many decades ago, a couple of decades ago, it's been ongoing.
Thank you.
Thank you. I must say, next year will be my 40th year in the NHS, and I've tried to stop myself from saying this is the most challenging time I've ever known, because I would agree with you. There's always been a challenging time. So I just want to echo that. We work really hard, and Charlotte will say something about this. Charlotte also sits on the London People Board and is really instrumental in both shaping and bringing back best practice, but also is well linked into the national. And I think you're absolutely right. There are some characteristics about North West London that make us a more and less attractive place to be. There are pluses and there are also negatives. Cost of living in the centre of London, for example, inner outer London waiting can be barriers. But there are also some great things about working here. So we work really hard to make sure we're not an island. And I just wonder, Charlotte, if you could give a couple of examples of the sorts of things we take to and from national and London, because we pride ourselves on being well networked.
Absolutely.
Charlotte, I wonder if you can just explain or talk about in your answer the positives that Claire has just alluded to and what Chetna and Claire was talking about earlier. How are we talking up North West London to attract? I know there is the problem all over. We aren't unique, but how are we talking up North West London to attract many more people than normally would otherwise?
Yeah, okay.
I'll bring moving after you, Charlotte.
cover those points. So in terms of the sort of that cascade, there's a national programme called Futures, so that allows us to be able to understand the best practice that's then disseminated to the London People Board and outwards. So a couple of practical examples of things that we've done are around retention. So there was some retention pilots across the country where there was retention leads embedded in trusts, but also embedded in systems to be able to understand from staff directly what it was that kept them in a trust and what attracted them to an area, so you could understand that, but then working at a system level to be able to sort of spread and scale that really quickly. So you had a learning in a trust environment, but you were able to bring that out quickly into a system and spread and scale that. So one thing that we've done is now drawn down some funding to be able to have our own retention lead. So we've got one embedded in Imperial and one embedded in North West London now to be able to understand best practice in retention. So we've picked out, for example, flexible working is one of the big things that staff are telling us through the surveys. And we're looking at our Flex for the Future programme and how we can look at that across the London area. So we've got, can just do it once, but actually use the policy once rather than all rewrite policies. Another example of that is around our talent management and the leadership development programme. So again, through the Regional Talent Board, which Leslie chairs, we've developed the leadership programme that's linked to the Messenger report. And we've taken forward a number of those modules, but at a system level to save us all procuring those individually. So to save us money, we've actually implemented those at a system level. Then in terms of how we're promoting North West London, so we attract people to the area, it's about promote what we're doing. So, for example, most recently, I chaired a panel at HPMA National Conference to talk about London North West. Our occupational health team went off to a national conference to showcase what they're doing on a shared service. The work that the lead employer did at Chelsea and Westminster was showcased as national casework of good practice. There's lots of things that we do to make sure that we take that stage to attract people.
Thank you very much. Thank you very much. Thank you very much. Let me bring Lucy in, please. Lucy, thank you.
Thank you. I think this goes quite well after Chetna's question, but I just wanted to understand what you talk in your workforce slide about the increasing numbers of people leaving the NHS. For first year leavers, turnover, retirement numbers all increasing. I just want to understand from this data, and I'm sure you're tracking it, what you're learning. And actually, if we do address this and people are not wanting to leave after a year or just feeling probably burnt out after the pandemic, we probably wouldn't be having the workforce shortage that we're having at the moment. So what is the NHS doing to change this?
Thank you.
Yeah. Just to say, I think as a rule, we try and talk about retention and recruitment, not recruitment and retention, because it's like filling the bath with the plug out if you're not really focused on retaining staff. Charlotte's alluded to one of our big points of learning, which is flexible working is valued by a huge number of staff. And we've got more training and awareness raising to do with our managers across the piece, because when people come to you and ask for more flexible working and you're really under the cosh if you're a ward manager, it's tempting to say no, not possible. And there's an education thing there, which is it's absolutely better to work flexibly with people who've got caring responsibilities, health issues, are getting older, whatever their reason is. So I think flexibility is a really huge piece around retention, as is, we know, career progression. I think there are some wider market factors, and Charlotte will say a bit more in a minute, but we have to work with London and those around us, because there is no doubt that what's going on at the minute is an overheating of the market as well. So people are being tempted into working with agencies or working for other trusts because everybody's undercutting or overcutting each other, offering more and more. And we do need by way of salary. And at the moment, when we're in such times of recession and economic hardship, staff are more likely to be guided by salary than they would otherwise be, for reasons we all understand. So there is something about working collaboratively with others so that the NHS isn't just going up and up and up and up and into a bidding war, where all that does is cause mass instability in the workforce. Charlotte.
Please.
Sure, somebody.
Beg your pardon, I was stuck on mute there. It's probably also worth saying in terms of those figures, they do include people that are progressing, so turnover figures that we report nationally. So we need to sort of think about our data as well, and what we disaggregate from the data to see the core that are leaving. Of the leavers, roughly going from memory, 40% are actually going to other trusts in North West London. So how do we optimise, people moving around so our career pathways across North West London support the progression of our staff? So some of the work that we've been doing under the talent work stream is to think about the career pathways that people have, not just within trusts and across professions, but across the system and across health and social care as well. Pay terms and conditions is obviously a big one, which is why we're seeing the response to the industrial action. But we've taken a lot of things on board there in terms of things like looking at our bank rates, London living wage, things like instant pay that we've put in place for our staff, and also schemes like retire and return and what we can do to attract people back, and things like our reservists. So when people leave, they move into a reservist pool that they can come and work with us in times when we have peaks of demand. So we try and optimise things we can do to understand that turnover, but use it as well to our advantage in terms of keeping people.
Thank you very much indeed, both Claire and Claire and Charlotte. And I would just ask that you take away and thank all the frontline staff for the sterling work that they do day in, day out. Thank you very much indeed, Claire and Charlotte. So before we progress to the next item, let me just bring Natalia. Natalia, for your recommendation, please.
Thank you very much, Chair. Yes, for the proposed recommendation, and I hope you will all endorse it, is for tackling racism towards the NHS staff to be explicitly part of the workforce strategy. I understand that also Councillor Crawford would like to add.
Well, I just think so. I think what we heard from Claire and Charlotte was that it explicitly is part of the work they're doing. It's just not mentioned in this particular slide pack as clearly as we would like. So perhaps, and we heard about some of the work that you both highlighted. Perhaps you could put some information in writing about that to the committee, and then we can ask you for more or to speak in more detail. Future meeting when we have more time.
Thank you very much. Thank you. Anything else, colleagues? Okay, so my thanks again to Claire Murdoch and Charlotte Bailey. Thank you very much. I don't know whether you want to remain for the other item, but you're very free to leave. Otherwise, equally very free to remain for the remainder of the items. Thank you very much.
Thank you, Chair. We have to return to our board. But may I just say one last thing, which is I think the fruits of the partnership in North West London, and asking ourselves, not are we an anchor institution, but are we good anchor institutions with regard to employment, is a really big prize that I think we are making great progress around. So I just wanted to thank partners really and say I think the opportunity is there for us. Many thanks. We have to go back to our board meeting.
Thank you very much, both.
Thank you.
Thank you. Thank you.
All right. So we now progress the meeting to the item number 7, which is the ICS update, please. And Rob, you're going to be leading on this for us. Thank you.
Thank you, Chair. I'm going to keep my overview relatively brief on the basis that there's a lot in here that you may wish to ask questions on. So just about 3 comments. Firstly, we've discussed at this meeting the state of pressure in the health and care services as we head into the winter. And I think it's implied through all of our discussions the absolute imperative and importance of working in partnership with all partners across the system, local authorities, voluntary sector, all elements of the system are part of the solution rather than any individual component. And that is the ethos ultimately for why we have created something called the integrated care system. And the state of play of that is that we, the ICB, as it's called, NHS North West London, came into existence on the 1st of July. That we did publish a constitution, but that is still has a number of things in draft and acknowledged need to change going forward as we build the partnership and ways of working going forward. So we are still in our early stages of how we will work together, and that is still being formulated in partnerships. I just wanted to make that clear. And in that whole operating model, if you like, how we're operating, the boroughs, the borough-based partnership are a fundamental component, and working with local communities are a fundamental component of what we're doing. Where we are in terms of what on earth are we here for to do, we have three key things. We have to agree a strategy for the residents and population in health and care, and we as NHS London, working with the 8 local authorities, need to bring that together. There is no, that I think is something that will be evolving over the months ahead as opposed to a point in time. We follow an NHS planning cycle. We've got all the boxes we need to tick in terms of an annual operating plan for next year. But the spirit that we need to co-produce that, build on the great work that's taken place in boroughs to date, it's an evolution of that. It's not a revolution, a different approach. Will be built into how we do things going forward. So it won't be a 5-year strategy agreed without consultation and co-production. It will be something that evolves over the year ahead, and will continue to iterate. Under point number 2, in terms of if we talk about what we're here for, strategy, delivery and assurance, under delivery, we've talked today, and I won't repeat, many areas where we are contributing to the coordination across the system of and convening elements of the system, looking at data evidence, doing the hard yards of how do we get that balance between equality of access, the equality of resource distribution, working between the components of different borough-based geographies and the scale that we need to create and learn from best practice across that. So that is what we are doing, and we also have the duty, still as the Commissioner, to be doing the engagement, the involvement and the consultation of significant service change. So that will no doubt be a feature of what we do, and feeds through some of the comments in here. And then finally, on assurance, we work in partnership with NHS England on how we're doing across the system, the performance that we have. And at the moment, as again, I won't repeat all the things we've been through today, and it gives you a flavour of where we are as a system, getting the assurance from residents around that.
Thank you very much for that, Rob. Grateful to you. Dan, please.
Yeah, so I have a couple of questions, which won't come as a surprise to Rob, I don't think, but I'm very grateful for what is right at the beginning about the governance arrangements progress made and mentioned in the board. It's clear that colleagues have listened to our feedback on that, and indeed was discussed in the most recent meeting recently, so we're grateful for that. A couple of comments just on the bit that follows underneath that is 3.1, communication, other forms of communication. I think this is the area that's of most interest to this jobs, really, because my frustration is local authority leaders, cabinet members, executives, they have the routine to structures already, because they will sit on some of these, you know, the scrutiny role is important.
Yeah.
But we are asked as individual borough scrutiny chairs to cover a wide range of areas. It's going to be impossible for us to scrutinise the ICS locally, I think, unless we have. Your suggestions are interesting, and I think it'd be interesting to get into the individuals' comments, individual members' comments via email. I think on how best to do that. Just in terms of invite people to join a meeting, I would not to fall out with Councillor Mason, who I think is identified at the bottom of one of those, my councillor. I would just seek to perhaps widen the engagement, wider than the leads in these areas, because individual councillors and chairs of scrutiny will be able to pick up on different things that may relate to the ICS workstream. That's very much my individual view. Colleagues may send from it, and they're welcome to and should. And then, Chair, with push for time, I have to note the irony in 3.5 with relation to the proposals for the Gordon Hospital. We're talking about here the report specifically states, the paper specifically states the formal consultation on the Gordon Wards is planned for 2023. The irony of there being a formal consultation on what's going to happen to the Gordon Ward when ourselves, Councillor Groves, Councillor Colton, colleagues in Hampstead, but Councillor Charlotte in Hounslow have approached over a period of time, Dr. Hilton, with regards to the changes to mental health services in England and been denied the option of full consultation. And it is the NHS position on those mental health beds that we will go for only enhanced engagement. We're grateful to Dr. Hilton during the time after this meeting to discuss that matter, but the difference has been noted by the authorities and by the residents. That is, I'd be interested in your comments on how we've arrived at a position where one is justifiably a full consultation and accepted as a need for full consultation, which is what this report states, and one is not. And that is something that I don't understand.
Thank you, Dan. Sorry, thank you. Rob, a quick response would be appreciated.
I think I'd need to give a more considered response than I'm about to, but in terms of my immediate reaction is that, I mean, there are essentially all service changes are subject to, there's a set of regulations and rules around that, and judgments have been made outside of here, not by myself, on the balance between those two things. Happy to go away and look at it. It's often that judgment is made also involved in engagement partnership with those affected by it. So I think we probably need to have a look at what you're describing there. But in here, points about that elsewhere there's been a judgment made on engagement, and I wasn't prepared to. So I will outside of here. Yeah.
Thank you for that. Jekna, please.
Supplementary on that, Harrow welcome, more engagement and more specialist meetings, because there's a lot of community that's knowledge is specific to each borough and each maybe area, community sector that I believe could feed into, your plans. So Harrow welcomes more involvement. Also thanking the change of LNWH to move Central St Mark's to Central Middlesex, because that's really helped with backlogs and really streamlined. So, thanking that decision. If I can come on to just with the new contract that's mentioned for Harrow, will it span across 10 years to ensure continuity and stability?
Thank you. Rob,
You give me a page number, sorry.
That's page 58. Procurement.
So I'm not aware of the timescale off the top of my head. Does it mention 10 years in there?
So the predecessor contract was 10 years on
Yeah, I mean, yes, to the best of my knowledge. I mean, there'll always be break clauses in 10-year contracts and reasons why that doesn't necessarily last for 10 years.
Thank you.
Absolutely.
Writing.
Yeah.
Sure.
Yeah, thank you.
No, that's okay. Thank you. And talking about procurement update, I just wonder what's the latest on UGC list?
So we haven't ruled on that yet. It's been a very significant procurement exercise, a very important procurement exercise, given the conversation about that. So we envisage a decision very shortly.
Thank you very much. Marina, please.
Yeah, just with regards to the GP hubs, obviously, we mentioned it in the previous meeting that sort of residents of Hounslow, depending on what part of Hounslow they're in, have difficulty getting GP appointments and face-to-face GP appointments. We're still seeing that strain of people being able to get appointments, and that's possibly putting the strain on the Western Middlesex Hospital, obviously with Strep A. Yep. At the moment, it's because they can't get their GP appointments, and they can't get the appointment in the hubs as well. I mean, I had a personal experience the other week with my daughter. She was unable to get a GP appointment. I then requested about the hub, to be told that my surgery told me that they was only issuing 2 appointments that day, and they'd already gone at 8:05 that morning.
So what is the picture with the face-to-face appointments in particular, right across the Northwest? London system level?
So as I said earlier, we're at about 140% correlative to pre-pandemic of total level of primary care patient interfaces, system including more 63% of that latest run rate and rising of face-to-face contact. So in terms of the volume of face-to-face contacts, they're now equivalent if you took these two numbers together to pre-pandemic level. I think whatever I say about the data, we have to acknowledge the real lived experience of people, primary care, and not least this week, with the issues that we've talked about with Strep A and vaccination, the level of 111 demand, the level of people trying to book in to primary care, and it's really appeal for me in this setting to, our GPs are massively overloaded here and now. This week are seeing 60 patients a day each. Our UTCs have a significant numbers of people flowing into it. So although we have more appointments than ever before, more face-to-face contacts than ever before, many new systems implemented to try and make that process better for residents to access into those appointments, that those systems and processes, as soon as we put them in, become overwhelmed by the tide of demand.
Yes, even with all of that work, Rob, the fact is it remains for all of our residents that they simply can't get those appointments. So despite what you're saying about all of that, and also we have something called some system called I forget the name now.
Patches, the online consultation platform.
Patches, and as Marina was just describing, those are bookable appointments online or however that system works, and there is a fixed amount or there's a set amount that is given to the PCNs or the surgeries, and once those appointments are gone, they're gone, and just like Marina was describing, you just can't get the appointment, which then means, as we were talking in the earlier papers, with the winter pressures and the elective work and all the other stuff that we spent a lot of time this morning, it has that domino effect, doesn't it? So, you pick up the patches or whatever the system is, you can't get the appointment. So what do? You turn up to A&E, and then, you have, that merry-go-round situation.
Yes, I could leave it at that. I mean, Patches is in as the online consultation is in 7 of our 8 boroughs. The feedback is since July, those that do use it find it prefer that platform to eConsult and other platforms that have been in there. I'm afraid my answer is going to be the same. We have significantly more appointments available than ever before. And we need to keep ramping up that to provide more access into it. And as I say, with all the systems and initiatives we're putting in place are trying to make picking up the phone easier, trying to make online consultation, trying to increase face-to-face where appropriate, between
and again,
patient.
For a florist team, how much are we getting? My earlier question, repeating my earlier question, how much of the engagement, how much of the communication, is there to ensure that people understand all these different systems and all these different pathways. It's just too complex, and it's a simple thing you do. As an individual, you pick up the phone. If you can't, then you just turn up at the A&E.
Yeah, and it's a big part of our winter campaign. Where to get help then. Lots of campaigns around that. It's a big part of it. I was talking all the time about it. It's complex. It's just about volume. Ability of appointments, but it's a big focus of our communications engagement.
Dan and Lucy, Dan?
No, I'll just be very, very, not to dissuade from anything anybody said, I would say we, at our Ealing health screening, only last week we took a report, a long-awaited report, it has to be said, on access to primary care, right? And the impact of the adoption of the Ealing standard pre-pandemic, and what that has delivered for residents within Ealing. And we now have a much better, and actually the data and the work of Health Watch and other partners in examining the patient flow and what patients actually want was really useful. And I know other boroughs, other screening homes are looking at this as well. I was just thinking, the opportunity of the ICS, and I wouldn't underestimate the complexity for constituents of understanding another NHS reorganisation and how it all fits together. Because all they want to do is be able to go and see their GP. Oftentimes the same GP that served them, and they're the people they understand. They don't really want to go into an A&E setting. So I think there's just an opportunity through communications, through explaining what the opportunity the ICS has, and working across the North West London footprint to equalise that.
And perhaps UTCs have a role to play even more. Perhaps the primary care hubs have even more role to play. And I think, I know you're doing all the amazing work and all the rest, but I think, as Marina was saying, the fact of the matter still remains that people can't get the appointments. And I think, there is something around, connecting those dots even more than we are perhaps doing, tirelessly day in, day out. Rory.
I was going to say, so in the new year, we are planning a campaign with general practice around how general practice works, what some of the challenges are, a public campaign. So we will come back to that.
Yeah, I mean, even in advance in sharing some of the matters, what you're, I don't know if you're allowed to do this, still planning a campaign. And
perhaps this committee can fit into it.
Maybe we can be a focus group
That's actually a suggestion.
Thank you.
We'll come back to you on that.
Let me bring Chetna in, then Lucy.
Okay.
Thank you.
Coming on to the proposal for the elective orthopaedic centre, noting page 66. Depending on where you live within the North West London, if you live down towards the south, west, or the north, the increased travel time to the orthopaedic site. Will there be patient transport services for certain people?
So consultation is precisely to try and get a feel for that. So just a couple of again context setting things, which is when we're talking about the sort of the elective orthopaedic centre to maximise the number of patients we can treat. Just bear in mind that actually we're talking about patients who we call ASA 1 and 2, so they are very low risk. These are our low risk patients. So our high risk patients will still be seen, and our most complex patients will be seen at their home in their home setting. So that's the first bit of context. The second bit is we will have to. So patients who need transport already will to any of our hospitals. And bear in mind, these are elective cases. Many of our patients have to travel between our hospitals now. Perhaps we don't articulate that enough, actually, because in North West London works across the specialties pretty much together. And many patients already do go to different hospitals. But that of course is part of the consultation is the bit that needs to come out that says what is the size of that issue. And what is our response to it? I think is we haven't got it, but we do need to bear that in mind.
Thank you.
So I don't wish to labour the point, but we've talked a long time around transport in this particular part of West London. But we're delighted at investment that will come in to try and tackle some of these problems. We do need to look at patient flow, whether it's through the patient transport that Councillor Elias outlined, or if it's just normal transport. We are going to need to lobby transport partners in respect to improve.
So we have.
No, I know you have. We're going to need to do it again because the math is quite clear. But I can tell you, even getting from Central Middlesex to Ealing and Charing Cross to Ealing, well, you know.
Yes, Rob.
Having done these reconfigurations elsewhere, the consultation outcome, the transport analysis, the assessment as all part of the process is very useful ammunition with the transport authorities as an evidence base that I'm sure we can work together on.
Okay, before we run out of time, don't want to keep anybody waiting. Yes, Natalia, then
I'm so sorry, just have a very last question. Going back to that constitution and governance, and I know what you said about how we welcome the recognition that you give to local authority partners, really good. I know from the papers as well that the action is for the constitution to be amended. Just for my clarity, has it been amended or is it in a process? Is there a timeline?
So we submitted to it. So as far as we're concerned, we're operating as if that is the constitution. we need to send it up to head office. We're not expecting that to be a problem, but they haven't communicated us a timeline of that. But I expect it to be a couple of months, something like that, in terms of their formal ratification. But we're going to operate as if that is our constitution.
Okay. So just to be clear, the expectation is the boroughs will be able to send.
Yes, correct.
A couple of representatives to future meetings.
Correct.
Thank you.
We're operating in line with what we consider to be the constitution,
Okay.
whilst it is waiting to be formally ratified, because we consider that a low risk approach.
Okay, if you keep us in loop as things develop. Just very quickly, just 2 or 3 quick points, please, Rob and colleagues. Leslie and people were doing amazing work around vaccination, particularly.
Thank you.
And just looking at the ICS update, it's literally disappointing that the numbers around flu vaccination, the uptake is not as great as I would have hoped, with Pippa and Leslie, being there driving that. Why is that, Liz?
So I think there's a number of things. So I won't go around the stream and say you said the vaccination actually, but and in fact, if I'd have thought about it, I'd have brought the syringe and needles with me. But anyway, I guess that there is something of both public and staff actual exhaustion with it all. If I'm being really, really frank about it, which is, and we've got to work with that. All of us have got to work really hard to try and get, because
otherwise, that can just add on to the weaker pressures.
Absolutely. Absolutely. Every single platform we have, we try and talk about this, and somehow or other, we haven't quite garnered either the public or indeed in some cases the staff real buy-in to it in the way that we managed to. In the middle of the pandemic, that's the honest truth.
And I assume.
Sorry.
Yes.
Can I just give a very brief personal example of this, which is last year when I had my flu vaccination, I was in my house during the on-call there. Somebody had to come and give it to me. And when the GP surgery offered me my repeat flu vaccination, it was meant to be on the same day as my COVID booster in the same arm. And we decided that wouldn't be an optimal outcome. So I had my COVID booster, but I'm still waiting for my,
Feel free, come down to us.
No.
Great.
Of course I will, but I'm just saying sometimes the systems that we set up don't always communicate with each other. And as somebody pointed out, if we can't get me, how am I meant to go and advocate for people who are, I have a high, my ward in Ealing is one of the highest ward sort of vaccine review things, either for COVID boosters or for flu.
Great, yeah. Thank you. And you said, Leslie, that you're using all the platforms, and I assume that means that you're using all the platforms, and Rory's team is really engaged in promoting this as much as you can.
If we were talking about ask for help, actually the local authorities and yourselves did an amazing job during the middle of the pandemic, working with. We didn't always have the most comfortable time together, but we did an amazing job. But there is something that says, please, and I know you are, but please, every one of your members, if you can get them saying the same thing, it really helps.
Thank you. 30 seconds, Rob. A quick reply from you. Sickle cell. What's the feedback that we are hearing, and how are we going to be monitoring that feedback, and how are we going to make sure that the feedback is going to be our learning to keep on making that service better than it is what it it is today.
Well, so as with any service engagement and consultation, we're picking up the feedback and the involvement of users, and we'll be publishing what the so what bit out of that in terms of what the recommendations are going forward. I think this is a area of focus. We've agreed it to be a service focus for across given the dynamics and the inequalities around it. So that we're committed to publishing the outcome of that.
Okay, great stuff. Thank you very much. Anything final point? Rory, please.
In terms of the electoral feeding consultation, is the committee planning to respond formally to that? Just because it closes in January. So it's too late, is it?
Sure. So before the closing date, the committee will have a quick chat, and then we will come back to you.
Just like historically, Chair, the committee's not responded as a sovereign body in one response because we're effective.
Yeah.
And it's more effective to have individual boroughs and representatives feed in.
But I think
To check.
yes, but I think I intend to have a discussion as a committee, and will certainly communicate to you as a committee, as a JOSC in coming days. Thank you very much for that. Thank you. I'm not aware of any other urgent business. So guys, thank you very much for all your help this morning, and to all the colleagues on the screen and those residents who were listening to this. Thank you very much. Until we meet next time. And if I don't speak to you before the Christmas break, season's greeting to you all, and hope you get a chance to have a few days off. Thank you very much.
Thank you.
Thank you.
Well done for keeping down under control.
Very good.
Thank you.
Oh, right.
I think